Good afternoon. My name is Adam Pugh, and I'd like to talk to you today about my research. And I did recurring anterior cruciate ligament tears in a Division III collegiate football player. So the purpose of my study was to determine the appropriate rehabilitation protocol for a recurrent ACL tear, while being able to highlight any possible complications or setbacks that may surface. And throughout the presentation, you'll see some pictures, and those are just some exercises that I had my subject participate in. So some background on the history, or background on my subject. He's an 18-year-old male football player who tore his right ACL for the second time in 2 years. He is 6 feet 2 inches and weighs approximately 260 pounds, and he plays defensive nose guard. His injury occurred this past preseason in a practice out on the practice field where he was attempting to shed a block, an oncoming block, and his right foot and ankle were fixed and planted, and the block was coming from his left side, so he rotated to throw the defender, and his knee buckled immediately, resulting in his torn ACL. In the middle of the slide, you can see that there's kind of a background timeline of how everything plays out. So his first ACL he tore that back in February of 2012, where he received a contralateral patellar tendon. And we all know that contralateral is, they took the patellar tendon from the left knee and used it in the right. His second ACL was torn on August 28, 2013, where this time he was chosen and he received a cadaver graft. You can see that his MRI happened 3 weeks afterwards, after his initial injury, and then his surgery didn't occur until more than a month after his MRI, which we'll see later plays into an effect of why I wasn't able to continue with my research. Next. So what did I do with my subject? Well, we met Monday through Friday for about 45 minutes to an hour and 15 minutes, where Wednesday was his off day. And I conducted his rehab sessions on Monday, Thursday, and Friday, and then Melissa Davis conducted them on Tuesday for me because of class conflicts and things like that. So we met Monday through Friday except for Wednesday, and I created a rehabilitation protocol that consisted of 5 phases, where you can see the timeline of that. It consisted of an immediate post-surgical, an early rehabilitation phase, an intermediate rehabilitation phase, an advanced rehabilitation activity phase, and a return to activity. Now, if you want to look on your handout, you'll see that, or you can peek up here. So for phase 1, my goals were to eliminate pain, swelling, and inflammation. So a lot of it was putting them through the modalities, trying to get that out, and then really focusing on range of motion exercises. So flexion, some extension, things like that. But you'll see the red section where we weren't able to do the heel slides in the beginning because this incision site hasn't fully closed. And then we get down to the strengthening, and we're still 0 to 12 days, so we weren't really focusing on strength at this point. We were just trying to get the pain, the swelling, and inflammation out. So we were able to do some strengthening, but not a lot. And as we'll see throughout the rehab program, that all these exercises, strengthening mostly, they can be added in resistance, whether that's changing the reps, changing the sets, adding weight, increasing the time, moving it from 2 feet to 1 foot, increasing proprioception that way. And as we get into phase 2, we're still 12 days after surgery, so we're still doing some modalities to get rid of it, to get rid of the pain and swelling and inflammation. We're able to do more range of motion. We're really able to start more extension exercises, and we were able to get back into our heel slides because after the 9th day, his incision site closed up. And then we were really able to start focusing on more strengthening exercises. And again, these can all be, these are kind of just baselines. These we're able to increase in resistance and sets and weight. For phase 3, his pain, swelling, and inflammation had all subsided, so we didn't need to do modalities. Range of motion, he had already regained everything, so we didn't need to do that. So we were able to more focus on strength and proprioception. And then phase 4 and phase 5, you can see from the timeline, I'm not yet able to get to that, so that's why my research is mostly ongoing. And then this is just the next the next part of it, where phase 1, there wasn't any proprioception going on because we were still in the initial stages. Phase 2, we were able to start something light, single leg balance on the floor, but no functional training as well. Phase 3, 6 weeks to 4 months, we're able to do a little more proprioception, really start focusing on that, and which is where he's at now today. He's actually 7 weeks and 2 days post-surgery. So he, phase 4 and phase 5 are kind of yet to be determined. Those are just things that I see myself doing with the athlete, but obviously they're subject to change. So for my results, we see a significant increase in his range of motion from day 1 to day 17 of his rehab. He started off with 61 degrees going up to 125 degrees. The biggest jump is between day 1 and day 3, and that can be contributed to the fact that modalities were being used. We were able to eliminate some of the pain, swelling, and inflammation, which from previous research I found that those 3 factors can limit a patient's range of motion. The area where it stays the same, here and here, that's mainly due to the fact that this is flexion, and we're still in the beginning stages, and flexion isn't as important as extension early on. Research has shown that flexion will come with time doing more exercises. So my more focus was on extension. So then you can see from extension, there's also a significant increase from day 1 to day 17, going from 7 degrees of extension down to 0. So we returned back to within normal limits. Again, the biggest jump is between day 1 and day 3, and that's simply just because we were able to remove the knee from the locked knee brace. We were able to get it moving. We were able to start doing more extension exercises. The area where it stayed the same can be contributed to the fact that, what I said before, there's still some pain, swelling, and inflammation going on, which can limit the range of motion. And as I said before, extension is the more crucial range of motion early on. And there's actually, some studies have shown that there's like a 2 to 3 week window where a patient must regain their extension, or else they can show complications later on in life, whether that is a chronic pain or a permanent extension lag. That's training. So then we get into swelling. And the swelling was kind of up and down, it was all over the place, but again, we still see from day 1 to day 17 a significant increase, going from 3.5 centimeters of swelling down to 0. Here the biggest jump was between day 5 and day 7. And then again, this is modalities working, getting out the pain, swelling, and inflammation. The area where it stayed the same, where it increased right here, can be contributed to the fact that range of motion exercises, strengthening exercises are going on, which are going to increase blood flow to the area. It's going to increase inflammation, which is going to ultimately result in increased edema. So as we move into some of the complications, some of these have to do with surgery and some of these are dealing with the rehab. We see that as you have a revision surgery, that there could be a complication of graft choice materials. So a physician is limited in which materials he can choose. Obviously, he had contralateral patellar tendon, so he wasn't able to take that patellar tendon again. So he's kind of limited in what he can have for his second surgery. The next one is choosing a good, strong place for tunnel placement. Since it's already been drilled in, they now have to find new places in the bone to drill the graft in, which can also play a factor into it. Third one is a problem achieving adequate graft fixation, which is similar. There could be hardware removal that has to happen, whether nowadays there's bioabsorbable screws, but sometimes people have metal screws that have to be removed in order to put the new graft in. The site of the incision, determining that, could also be a problem, because they have to go over the same area. Now, the big one is the type of rehabilitation needed to fully recover. And I found research